10 metoprolol side effects doctors won't tell you. Metoprolol is currently the fifth most prescribed medication in the United States, with nearly 75 million prescriptions filled every single year. It is arguably the cornerstone of modern treatment for hypertension and heart rate control. Because this drug is so ubiquitous, there is a widely held cognitive bias that common equals fully understood. We naturally assume that if a side effect was truly significant or life-altering, it would have been the very first thing mentioned during the brief consultation when the prescription was written. We tend to trust that the standard warning label covers the entire scope of the risk. But the pharmacological reality is much more complex. Advanced clinical data reveals a specific set of systemic interactions that go far beyond what is printed on the standard pharmacy pamphlet. These are profound physiological shifts that often fly under the radar during routine monitoring, yet they have the potential to fundamentally alter long-term health outcomes. Today, we are breaking down 10 of these specific metoprolol side effects that are almost never part of the initial conversation. Please note, this video is for informational purposes only and not a substitute for medical advice. All information provided has been carefully verified. Source links are available in the description. 1. Bradycardia. Let us begin by examining the most direct physiological consequence of taking metoprolol, which is bradycardia. This condition is clinically defined as a resting heart rate that drops below 60 beats per minute. Metoprolol exerts its primary therapeutic effect by selectively blocking beta-1 adrenergic receptors located specifically in the heart tissue. By docking onto these receptors, the medication prevents adrenaline and norepinephrine from stimulating the heart. This blockade leads to what medical professionals call negative chronotropy, which is a fancy way of saying it reduces the rate at which the heart beats. Furthermore, the drug causes negative inotropy, meaning it decreases the force of the heart muscle's contraction. The medication specifically inhibits sympathetic stimulation of the sinoatrial node, often referred to as the body's natural pacemaker. By slowing the rate of depolarization in this node, metoprolol prolongs the conduction time of electrical signals and suppresses overall cardiac excitability. While this mechanism is incredibly beneficial for patients suffering from tachyarrhythmias or angina, it can overshoot its goal. This results in symptomatic bradycardia, particularly in susceptible individuals or those prescribed higher doses. The risk becomes significantly more pronounced in patients with specific genetic profiles regarding their liver enzymes. Individuals who are poor metabolizers due to genetic polymorphisms in the CYP2D6 enzyme cannot break down the drug efficiently. Consequently, they accumulate much higher plasma concentrations of metoprolol than the average patient. According to a comprehensive review published in the Journal of Personalized Medicine in 2023, these CYP2D6 poor metabolizers experienced a markedly increased incidence of bradycardia. This was directly attributed to the elevated drug concentrations resulting from their impaired metabolic pathways. Furthermore, drug interactions with other medications that inhibit CYP2D6, such as certain antidepressants, can precipitate this side effect unexpectedly. 2. Fatigue and lethargy. Moving on to one of the most frequently reported quality of life complaints, we must discuss fatigue and lethargy. These symptoms are not merely psychological, they are rooted in the hemodynamic changes caused by the medication. Fatigue in this context is primarily attributed to the reduction in cardiac output and systemic perfusion resulting from beta-1 blockade. When metoprolol successfully decreases your heart rate and the force of contraction, it inevitably lowers the volume of oxygenated blood delivered to peripheral tissues. Your muscles and organs receive slightly less oxygen than they might be used to during high-demand states. This physiological shift often manifests as generalized tiredness, a notable reduction in exercise tolerance, or a pervasive sense of weakness. Beyond the cardiovascular system, we must look at the central nervous system, or CNS. Metoprolol is a lipophilic drug, meaning it can dissolve in fats and cross the blood-brain barrier to enter the central nervous system. This CNS penetration allows the drug to reduce sympathetic tone and alertness in the brain itself. This effect is particularly relevant for individuals with higher plasma concentrations, such as the elderly or the poor metabolizers we discussed previously. The sensation of lethargy is often dose-dependent and tends to be most severe during the initial phase of therapy. It can also resurface significantly after a dosage escalation while the body attempts to adjust to the new hemodynamic reality. According to a comprehensive review published in JAMA in 2002, beta blocker therapy is statistically associated with these symptoms of fatigue. While the review noted that the absolute increase in risk is small, about 1 case per 57 patients, it remains a clinically significant side effect. Patients often describe this not just as sleepiness, but as a heavy feeling in their limbs or a lack of motivation to move. 3. Bronchospasm and respiratory complications. A critical safety concern involves the respiratory system, specifically the risk of bronchospasm. Metoprolol is classified as a cardioselective beta blocker, meaning it is designed to preferentially target beta-1 receptors in the heart. However, this selectivity is not absolute and can diminish as the dosage increases. At higher concentrations or in highly sensitive individuals, metoprolol may lose its selectivity and begin to inhibit beta-2 receptors found in the smooth muscle of the bronchi. Under normal circumstances, stimulation of these beta-2 receptors allows the airways to relax and open up. When metoprolol inadvertently blocks them, it can lead to bronchoconstriction, a narrowing of the airways. This manifests physically as wheezing, dyspnea, which is the medical term for shortness of breath, and a persistent cough. This risk profile is particularly relevant for patients with underlying reactive airway diseases like asthma or chronic obstructive pulmonary disease, COPD. In these patients, maintaining open airways is dependent on beta-2-mediated bronchodilation, which the drug may antagonize. While many randomized controlled trials suggest that cardioselective beta blockers are generally safe for stable COPD patients, recent data urges caution. There is evidence of an increased risk for severe exacerbations in specific vulnerable populations. The mechanism is straightforward. Increased airway resistance makes breathing significantly harder for compromised lungs. A comprehensive review published in the New England Journal of Medicine in 2019 highlighted this exact danger. The study found that metoprolol was associated with a higher risk of COPD exacerbation leading to hospitalization compared to a placebo. Specifically, the hazard ratio was 1.91, indicating a nearly doubled risk in that specific study cohort. 4. Worsening heart failure and exacerbation. It may seem paradoxical, but metoprolol can temporarily worsen the very condition it is often prescribed to treat, heart failure. Metoprolol is a cornerstone therapy for chronic heart failure with reduced ejection fraction because it protects the heart over the long term. However, the initiation of therapy or a rapid dose escalation represents a vulnerable period for the patient. The drug works via a negative inotropid effect, which means it immediately reduces the strength of the heart muscle's contractions. In a heart that is already struggling to pump blood efficiently, this sudden reduction in contractility can precipitate decompensation. This leads to fluid backup in the lungs and body, known as volume overload. This phenomenon is most likely to occur during the early titration phase, when the body has not yet adapted to the medication. Clinicians must balance the immediate reduction in pumping power against the long-term benefits. Over time, metoprolol aids in ventricular remodeling, which is the repair of the heart's shape and function. It also suppresses chronic sympathetic overactivity, which is toxic to the heart muscle in the long run. To bridge the gap between the immediate risk and long-term reward, careful patient selection is essential. Doctors typically use a start low and go slow approach to titration to avoid tipping a stable patient into acute failure. This risk was notably detailed in the landmark MERIT-HF trial, discussed in a comprehensive review in The Lancet in 1999. The data confirmed that while metoprolol significantly improves survival and outcomes in chronic heart failure, the risk of early decompensation is real. It necessitates vigilant monitoring of fluid status and hemodynamics during the first few weeks of treatment. 5. Cold extremities and peripheral vasoconstriction. A distinct and physically uncomfortable side effect of metoprolol is the phenomenon of cold extremities. Patients often report that their hands and feet feel persistently freezing, or they may develop Raynaud-like symptoms. In Raynaud phenomenon, the blood vessels in the fingers and toes spasm, causing them to turn white or blue due to lack of blood flow. This side effect is attributed to the complex interplay between different types of adrenergic receptors in the vascular system. While metoprolol blocks the beta receptors, it leaves the alpha adrenergic receptors unopposed. Alpha receptors are responsible for vasoconstriction, or the tightening of blood vessels. Normally, beta-2 receptors help mediate vasodilation to keep blood flowing to the periphery. When metoprolol inhibits these receptors, even partially, the balance shifts towards vasoconstriction. This results in reduced blood flow to the arterioles in the hands and feet. Although metoprolol is beta-1 selective, this selectivity is not a perfect shield against peripheral effects. This is especially true at higher doses, or in the poor metabolizers we discussed earlier, where selectivity diminishes. The reduced cardiac output caused by the drug further compounds the issue by sending less warm blood to the extremities. A network meta-analysis of randomized controlled trials quantified this risk. It found that beta blockers increased the prevalence of peripheral vasoconstriction to roughly 7%, compared to 4.6% in placebo groups. According to a comprehensive review in the British Journal of Clinical Pharmacology in 2016, beta-1 selectivity does not confer total protection. The study confirmed that metoprolol was associated with cold extremities across multiple trials, proving it is a drug class effect. 6. Depression and neuropsychiatric mood changes. The link between beta blockers and depression has been a subject of medical debate for decades. The underlying theory involves the central beta-adrenergic blockade within the brain. It is hypothesized that by blocking these receptors, metoprolol may alter the activity of key neurotransmitters like norepinephrine and serotonin. Additionally, beta blockers are known to potentially reduce the body's natural production of melatonin. Because metoprolol is a lipophilic drug, it penetrates the central nervous system more readily than water-soluble alternatives like atenolol. This ability to cross the blood-brain barrier makes it more likely to cause neuropsychiatric effects. Susceptible individuals, or those with a prior history of mood disorders, may be at higher risk for these changes. Patients may report feeling a flattened affect, lack of motivation, or distinct depressive symptoms. However, separating causation from correlation is difficult in this patient population, as chronic heart disease itself is a major risk factor for depression. Large case control studies have attempted to clarify this relationship. The consensus suggests that the highest risk for depression is actually associated with propranolol, a different beta blocker, particularly during short-term use. Long-term use of metoprolol does not appear to statistically increase the risk of new-onset clinical depression in the general population. However, individual variation is significant. A comprehensive review published in Drug Safety in 2022 analyzed this data extensively. It concluded that while the elevated risk was primarily linked to propranolol, lipophilic agents like metoprolol still carry a potential risk for worsening pre-existing depression. Therefore, clinicians are advised to monitor mood changes, especially when therapy is first initiated. 7. Dizziness and orthostatic intolerance. Dizziness and lightheadedness are among the most immediate signs that the medication is affecting your hemodynamics. These symptoms are directly related to metoprolol's intended mechanism of lowering blood pressure and heart rate. By reducing cardiac output, the drug can sometimes compromise cerebral perfusion, the amount of blood reaching the brain. This is most evident during postural changes, such as standing up quickly from a sitting or lying position. This phenomenon is known as orthostatic hypotension. Under normal conditions, your body's baroreceptor reflexes instantly tighten blood vessels and increase heart rate to fight gravity when you stand. Metoprolol impairs these reflexes. It prevents the heart from speeding up sufficiently to compensate for the gravity shift. This leads to a transient drop in blood pressure and a momentary lack of oxygen to the brain, resulting in a head rush or dizziness. The risk of orthostatic intolerance is significantly increased in elderly patients and those with existing autonomic dysfunction. Furthermore, if a patient is taking multiple antihypertensive agents, the cumulative effect can be profound. The CNS effects of the drug, such as sedation, can further exacerbate the sensation of unsteadiness. According to a comprehensive review published in PLOS Medicine in 2021, the statistical link is strong. The study found that beta blockers were associated with substantially higher odds of orthostatic hypotension compared to placebo, with an odds ratio of 7.76. This drastic increase underscores the importance of instructing patients to rise slowly to prevent falls. 8. Gastrointestinal distress. While we often focus on the heart, metoprolol also impacts the gastrointestinal tract. Reported symptoms include nausea, diarrhea, abdominal pain, constipation, and bloating or flatulence. These adverse effects occur because the autonomic nervous system heavily regulates the digestive system. By blocking beta-1 receptors, metoprolol can unintentionally alter the autonomic regulation of gastrointestinal motility. Motility refers to the coordinated contractions of the gut that move food through the digestive tract. When these signals are dampened or modulated, the result can be either a slowdown, causing constipation, or irregular contractions causing diarrhea. There may also be central mechanisms at play involving the chemoreceptor trigger zone in the brain, which controls nausea. Although these gastrointestinal symptoms are generally mild, they can be persistent enough to be bothersome. In some cases, they lead to patients discontinuing the medication entirely. The risk appears to be higher in individuals who already suffer from pre-existing GI conditions like IBS. It is also more prevalent in patients taking higher doses, suggesting a dose-dependent relationship. Rarely, severe abdominal pain could indicate more serious complications caused by reduced blood flow to the gut, known as mesenteric ischemia, though this is uncommon. A comprehensive review published in PLOS Medicine in 2021 validated these observations. The review noted that beta blockers affect gastrointestinal secretions and motility through their modulation of the sympathetic nervous system. This systemic dampening leads to the clinical presentation of nausea and general abdominal discomfort that many patients report. 9. Hypoglycemia masking in diabetic patients. For patients with diabetes, metoprolol presents a specific and dangerous challenge regarding blood sugar management. The primary concern is the masking of hypoglycemia, or low blood sugar. Typically, when blood sugar drops dangerously low, the body releases adrenaline to warn you. This adrenaline surge causes symptoms like tachycardia, fast heart rate, tremors, and anxiety. These are the alarm bells that tell a diabetic they need to eat sugar immediately. However, because metoprolol blocks beta-adrenergic receptors, it effectively silences these alarm bells. The heart rate does not speed up, and the tremors may be significantly blunted. This leaves the patient unaware of their hypoglycemic state until it becomes severe, potentially leading to loss of consciousness. Additionally, beta blockers can interfere with the body's metabolic response to low sugar. They can inhibit glycogenolysis, the process by which the liver breaks down stored glycogen into glucose to boost blood sugar levels. They may also reduce peripheral glucose uptake and insulin sensitivity. This creates a complex metabolic environment where glucose control becomes more difficult. While cardioselective beta blockers like metoprolol are safer than non-selective ones, they are not risk-free. According to a comprehensive review in the American Journal of Hypertension in 1998, the risk of masking symptoms is significant. The review emphasized that diabetic patients on metoprolol must rely on frequent blood glucose monitoring rather than physical symptoms to ensure safety. 10. Sleep disturbances and vivid nightmares. Finally, we must address the neuropsychiatric effects of metoprolol on sleep architecture. Because metoprolol is moderately lipophilic, it crosses the blood-brain barrier and interacts with receptors in the brain. This property is strongly associated with sleep disturbances, insomnia, and notably vivid dreams or nightmares. The proposed mechanisms for this are multifaceted. First, beta blockers are known to suppress the secretion of melatonin, the hormone that regulates the sleep-wake cycle. Second, the drug modulates REM, rapid eye movement, which is the phase of sleep where dreaming occurs. Antagonism at central beta-adrenergic and serotonin receptors may also play a role in altering dream content and intensity. Patients often describe these dreams as unusually real, frightening, or bizarre. This side effect can be distressing enough to affect a patient's mental well-being and willingness to continue therapy. Elderly patients and those who are sensitive to CNS drugs are at the highest risk. This effect is a distinguishing feature between different types of beta blockers. Hydrophilic agents, which do not enter the brain as easily, tend to cause fewer sleep issues. A large pharmacoepidemiological study published in the Journal of Psychopharmacology in 2021 provided robust data on this topic. The study found that metoprolol carried a significantly higher risk of being associated with nightmares compared to other beta blockers. The adjusted reporting odds ratio was 1.89, confirming that for many patients, the side effects of this heart medication follow them even into their sleep. Thanks so much for watching. If you found this video helpful, please give it a like, and don't forget to subscribe for more science-backed health insights.